is the session then on total talus. This is a webinar from the United Kingdom, and we're delighted to introduce an excellent panel of speakers. I'd like to thank and acknowledge Selene for his sterling work. He's been up now for 23 hours, so he must be exhausted by now. A huge thank you to the Parekh Family Foundation and our sponsors, all of them, for making this event happen. I've got some amazing speakers I'm going to introduce to you. To kick us off will be Mark Davies, who is a consultant orthopaedic foot and ankle surgeon based in Sheffield, UK, and he's also the president of the British Orthopaedic Foot and Ankle Society. Mark's currently traveling, and so is caught on a plane. So with the magics of technology, he's going to present his talk by recording, and we're then going to move over to Toby Jennison, who's a consultant orthopaedic surgeon in Plymouth in the south coast of the UK. He's formerly the research fellow for the United Kingdom National Joint Registry, and is highly published on this and many other topics. And a final member of the panel is Mr. Ian Sharpe, who's a consultant orthopaedic surgeon in Devon and Exeter, which is the southwest coast of the United Kingdom. And he's an internationally renowned expert on really complex ankle surgery. So we're very honored to have this panel. And I'm going to start by introducing Mark Davies's talk.
So my name is Mark Davies. I work in Sheffield. I'm going to be talking today about the history of total talus replacement. Here are my disclosures, with the two in bold being the most pertinent to today's talk. So as I said, I work in Sheffield, which is a city in the north of England with a population of 600,000 people. Over the years, I've therefore developed an interest in avascular necrosis simply because I've been referred tricky cases. And my initial way of managing this was through excision of the diseased body, fusing the tibia to the calcaneus and applying a Lizaroff apparatus for lengthening. Unfortunately, this was very poorly tolerated by patients, and the foot shape I don't think is particularly good and is very stiff. I've also had considerable experience using femoral head allograft, which has been placed into the defect created from resecting their body of the talus and fixing this with a hindfoot nail. But as is well documented in the literature, I've had issues with graft resorption and failure of the construct. So I then was still looking for the Holy Grail and came across the trabecular metal spacers that are there on the right-hand side of the screen. And I did 12 of those and found actually that they were pretty reasonable, except for the fact that they had nothing to do with the shape of the defect that I was faced in the first place. So in other words, I had a problem and I had to effectively make that thing fit. So when additive manufacturing came along and we were able to make patient-specific implants for this particular disease process, I was cock-a-hoop. So here you can see quite a florid avascular changes within the body of the talus with collapse and considerable soft tissue swelling. These are the CT images relating to the same patient. You can see the dead, destroyed body of talus and neighboring arthrosis, particularly evident in the tibia-talar joint. And this has been my workhorse since then, a custom-made implant, replacing the dead bit, lagged on to the remaining talar head and encased in bone by using the superficial parts of the fibula. But the problem is that achieving pain relief is great, but there is loss of function, and patients sometimes come to you asking if there's any way that their joint motion in the hindfoot could be preserved. So that brings me on to the evolution of total talus replacement. And there's nothing new in orthopedics, but I think that the story of this goes back to 1974, where this clever doctor in Thailand called Han Roongroj started his journey with talar body replacements. He reported on these in 1997 in the JBJS. Essentially, I think he probably made this in his workshop, in his shed, using a slit scanogram measurement of the contralateral talus. He created a last out of stainless steel that was mainly a body with a peg for the neck of the talus. He then ground that last by hand to shape it and polished it, and then he implanted it. So in the initial paper by him alone in 1997, he revised 2 of them over the course of a fairly lengthy period of follow-up, and he described the outcomes as good. There were no other problems really to guide us. And then another member of the family, I assume it's a member of the family, was involved with a second paper over a longer period of time, looking at 36 talar body replacements between 1974 and 2011. Again, using the same manufacturing technique, but this time using a longer and broader peg for the neck and the head of the talus. So that assumes that there was an issue that they had determined in the group before 1990. The indications for the surgery had been extended to 2 bone tumors, one of which I believe was malignant. In 2014, the Han Ringrodges reported 33 of their patients, 3 were lost to follow-up, and 15% of those had been revised. That was because of collapse, deep infection, and bone tumor recurrence. 3 were revised to arthrodesis, 1 required a prosthesis revision, and 1 a transtibial amputation. In Japan, the same techniques had also taken off, and Taniguchi in 2012 reported 22 cases of talar body replacements. This time he was using alumina ceramic, and he'd done that manufacturing technique using CT, creating a wire model, then using a stereolithographic resin before creating the ceramic. He had 2 generations, 1 with a peg, and generation 2 had no peg. What he found was that the first generation all loosened and the head of the talus necrosed, and he revised 2 of those to a total talus replacement. Generation 2, where he'd removed the peg, 4 of them were revised to total talus replacement. So he had 6 early revisions within 2 years. His conclusion was that we recommend the use of a total talus implant in patients with avascular necrosis, even if the talar neck and head are preserved. So that brings us on to these 2 sports cars, the 3rd generation total talus replacements. Again, people are manufacturing them in ceramics, cobalt chrome, and titanium nitride. So why would we consider using TTR in 2024? Well, it's what I would term global avascular necrosis. So benign tumors, tumor-like conditions, large cysts, if the AVN affects the whole of the bone, or in some instances, post-ankle replacement. So global talar AVN, as illustrated with this case, a lady of 55 who came to see me a few years ago, spontaneous onset of AVN involving the whole of the talus without any neighboring arthrosis. So she underwent a cobalt chrome total talus replacement, and 5 years later, she's doing well and is happy with the outcome, is back at work. I then assisted Rick Brown in Oxford with this youngster, 16-year-old female. We waited for her to achieve skeletal maturity, but she had fibrous dysplasia of her talus, and this was becoming more and more painful. She was counseled about her options. She wasn't keen on a talectomy, fusion and lengthening because it was her formative years and would have interfered with her school exams. So she particularly was interested in a total talus replacement. And here you can see the intraoperative photographs taking out a really moth-eaten piece of talus and a slightly strange morphology of this talus as it has developed during teenage years. But what happens if there is an adjacent joint is degenerate? Does that restrict what we do with our total talus replacement? So if there's a subtalar arthropathy, if there's talar navicular arthropathy, if there's tibia talar arthropathy. Well, here's a case of a total talus replacement whereby there was disease in the subtalar joint, so articulations could be preserved in the talonavicular joint and tibia-talar joint. Similarly, the same methodology with talonavicular arthrosis, creating a fusion mass at the talonavicular joint, but preserving motion at the tibia-talar joint and the subtalar joint. What happens if there is tibia-talar arthrosis, or if you have some failed ankle replacements whereby the whole of the talus is lost? Then this can be revised to a long stem ankle replacement, and the total talus replacement can be fused to the subtalar joint and articulate with polyethylene. What's the evidence for total talus replacement? Well, Taniguchi reported on 55 ankles in 2015, and that was again ceramic total talus replacement, good duration of follow-up, and actually no revisions with improved pain scores, and all returned to work. Kodaka in 2020 talked about 27 ankles, a mixture of cobalt chrome and titanium nitride coatings, shorter period of follow-up, but improvement in pain scores. He was also very keen to emphasize that there were 3 complications, one which was deep infection that went on to below the knee amputation. So none of these surgeries are benign, and they are really last gasp attempts to try and preserve function and give pain relief. More recently, with the advent of more evidence, Sam Adams has published a systematic review in 22 of about 200 ankles, of which 19 studies used a 3rd generation total talus replacement. And he saw that there were promising early and mid-term outcomes, but he was aware that there is an appearance of neighboring arthrosis with time. So in conclusion, there is early evidence of promise with total talus replacement. It requires rigorous patient assessment, preoperative counselling, rigorous consent, and post-op monitoring and scoring. More evidence will come with time, and certainly further developments will be on the horizon, that's for sure. We're talking about advances in technology. Thank you very much for allowing me to speak.
That's great. So thank you, Mark. We're now going to move on to the second talk, which is Toby Jennison, who's going to talk about a systematic review that he's carried out. Toby, over to you.
So good evening. I'm Toby Jennison. I'm a consultant orthopaedic surgeon based down in Plymouth in the UK in the southwest. And I'm going to talk to you about total talus replacement. What is the evidence? So first of all, before we start this, we have to say that actually there is relatively limited evidence out there for total talus replacements. All the evidence is there is mainly small case series and numerous case reports, and most of them have short-term follow-up. But despite this, what can we learn from the available evidence that's out there? As you can see on the right side, we looked at this, and at that stage when we published, there was only 9 studies at that stage that had more than 3 cases in their follow-up. So looking at the main papers that we've got, you can see there's quite a large variety in where they come from, with a lot coming from the Asian subcontinent. You can also see there's on the majority, there's quite short follow-up, and with most of them being less than 3 years. And also looking at the comparisons, some are with or without an ankle replacement. Again, looking at the age, you can see the studies have an extremely large range of ages, with some having young patients which are below 30 and others being above 70. So this slide just looks at the characteristics and why it's so difficult to draw any conclusions currently from the literature that's available. As you can see, the indication is very varied. A large number have AVN, but one study, for instance, has patients with ankle replacement. Also, as we heard from the previous talk, they can be made from different materials. And a lot of these, such as the ceramic and cobalt chrome, makes interpretation difficult. So I think one of the most things we can get from the literature at the moment is looking at the functional scores following total talus replacement. And as can be seen from this, the majority of scores in the studies have shown significant improvements in results from pre to post-operative. All the other scores on there have shown non-significant improvements. So I think from the literature that's out there, we can at the moment say that at least in the short term, total talus replacements definitely do improve quality of life and function. Looking at total talus replacements, a few other things. So looking at range of movement, Kadaki et al. Surprisingly didn't find any change in range of movement post-operatively. But a study by Moderator with slightly larger study did show a significant improvement in range of movement from 25 to 45 degrees. Gait was assessed in 3 studies, and the study by Abramson et al. Found 7 of the 8 patients didn't have completely normal gait with some decreased subtalar range of movement and minor gait abnormalities after it. They also found some with hindfoot varus and some with discomfort on ankle movement. But on the whole, their gait was better than it was before the surgery. Angfon in their study found that the majority again did improve, but some had subtalar joint stiffness and 1 had limited weight bearing due to pain. And Katsui, 2 of the 6 patients had limited ROM, therefore meaning that 4 of them following this procedure had full range of movement, which I would have thought is classed as a good result. I wanted to highlight this most recent study, which was published last year. And this had a longer follow-up than most of them, which was 5 years, for 10 patients with idiopathic osteonecrosis. As can be seen on the pictures on the bottom, nearly everybody got considerable improvement in range of movement from pre to post-operatively. Also, I think the graph at the top is really good and shows the FAS pain score and how that's reduced from pre to post-operatively in all the patients, showing that at least in the short term, it does improve quality of life. Looking at the radiological outcomes from the studies, so these have been reported in 4 papers, with Kadakia finding 1 patient developed distal tibial AVN. Abramson found only 1 out of the 8 patients had any tibial wear afterwards, both of these showing that, at least in the short term, there wasn't any issues with adjacent joint wear. Angfong, again, didn't find any radiological signs of loosening. And Moderator et al. Probably published the most detailed data on this. They found tibio-talar osteophyte changes increase from 47% pre-op to 90% post-op. And in the talar navicular joint, this was 63% post-op compared to 16% pre-op. But despite these changes, they didn't think these affected clinical scores, and again showed good improvement in functional scores, at least in the short term. So looking at complications, all the studies have published low rates of complications. Kadakia, which was mentioned in Mark Davies's lecture, showed 1 episode of distal tibial AVN, 1 superficial infection, and 1 superficial perineal nerve neuroma. Only 2 other studies have presented any other complications which required surgery. So looking at survivorship, you can see this, only 2 papers have actually published any failures at all. The study by West et al., which was with ankle replacements, have found that 1 of the 3 had to undergo revision arthroplasty. And the study by Kadakia et al., there was 2 failures, with 1 requiring revision and 1 requiring a below knee amputation. All of the studies haven't actually reported any failures. So we've talked mainly about total talus replacement by itself, but you can, as mentioned, put this in with a total ankle replacement. And there's 3 studies have looked at this. Kinsaki put theirs in with a TNK ankle replacement, again from Asia. These had 22 patients with a mean follow-up of almost 3 years. And they did show an increased improvement in range of movement, and they found that all components of the Japanese score, the functional score, did improve following surgery. And they had, in these 22 patients, low rates of complications, and 0 patients required revision surgery. The publication by West, looking at total talus with a star ankle replacement, in this situation, they fused the subtalar joint with a total talus replacement, and 1 of the 3 patients required revision of the tibial component. The only comparative study we have is by Kurakura et al., and this compared 10 total talus replacements combined with an ankle replacement to 12 with a standard ankle replacement for end-stage arthritis. These found an improvement in functional scores in both, but they found the mean postoperative score was actually higher in the total Talus replacement and ankle replacement group than just the total ankle replacement group. They didn't, though, find any significant differences in the other scores, but still showing that total Talus replacement is an alternative to ankle replacement. Again, it has to be said this is a small study, so the results do have to be interpreted with caution. So the limitations of the studies, and this is really important to say, the majority of these are case series. And when assessing the risk of bias, they actually all have relatively high risk of bias when assessing it by the minus score. The majority of them also have short-term follow-up. And as previously said, there is a heterogeneity in the implants recorded and also the surgical techniques. It also should be said that some of the majority of the papers actually don't report any failures as well. So in conclusion, currently we do have limited evidence on total Talus replacements. It's all level 4 evidence. But what we can say so far is it does appear to give good short-term results in these selected patients, especially with functional outcomes. We can therefore say, at least in the short term, total Talus is an alternative to a more extensive fusion procedure. But further studies are definitely required to ensure good outcomes in larger cohorts and in larger term follow-up. Thank you ever so much for the opportunity to present this evening.
That's great, Toby. Thank you very much. I'm now going to go on and share my screen and talk about total Talus with ankle replacement. So my name is Andy Goldberg, and I'm an orthopaedic foot and ankle surgeon in London. And as I said, I'd like to thank Selene and the foundation for putting on this amazing whirlwind 24-hour session with some amazing speakers. I'm going to do a shameless little advert here. I run the TAVA study, which is a large funded study of ankle replacement against ankle fusion. And we currently have a TAVA fellow, Barbara Favia, who's in role, but she will hand over the gauntlet in Q4 of this year. So if there's anyone out there that's looking for a fellowship and wants to become a leader in the field of ankle arthritis, then do drop us a line. So Toby's really given us a lovely outline of the literature, and his paper was published in Foot and Ankle Orthopaedics. So it's open source, so anyone can download it, and it's just simply called Total Talus Replacements. So well done there, Toby. And there's been another review that was published in Foot and Ankle Surgery that's been alluded to by Sam Adams' group. And just to briefly talk about that, when they looked at total ankle replacement with total Talus replacements, the literature really is a bunch of case reports. Everything's retrospective. There's no prospective data. What Sam Adams' group has said, and I apologize for repeating what Mark and Toby have already said, but I think there's going to be overlap between all of the speakers tonight, obviously because this is a new and emerging subject. But in essence, the total global literature is only 136 patients. Interestingly, the majority of them are female, so much more females than males. I'm not entirely sure what the logic behind that is. And the average age, interestingly, although the range was 36 to 84, the mid or average age was 64. And it's very difficult because you can't compare a 36-year-old's outcome to that of an 84-year-old outcome. And pretty much, as Toby said, the majority of the evidence was level 4. People are doing them for all different areas. And it's interesting, even some of the papers that were included in Sam's report didn't report on sex, age, or etiology. So, you know, really we are looking slightly in an evidence-free zone. And the majority of those 136 patients were using what we now consider the first or second generation technology. So that's the alumina ceramic. These were custom made, but they weren't 3D printed. They were screw fixed, the tibial component, and they used an implant that's not used outside of Japan, which is the TNK Kyocera implant. So that's the majority of the cases that have been published. I won't labour on the results because Toby's already articulated that very nicely, as has Mark. Mark Myerson's and Roy Sanders published a really nice paper quite a long time ago now, looking at this whole topic, but they weren't really the modern generation implants that we know. These were, for example, an agility implant where the body of the talus was actually put into the calcaneum where the talus had been lost, usually for revision or salvage ankle replacement. So that's a slightly different animal. Selene really pioneered a lot of this work with his work on 3D, and so the first 9 patients were only published last year. So this is an example of a modern implant. So this is a modern tibial component linked to what is a subtalar fusion here, and you can see here that the porous coated surface is covered with, in this case, stem cell induced material, and then fused either with a combination of staples or screws or something to the like. So I'm going to give you my own personal experience of a case study which I think highlights the options available in this very complicated scenario. So this is an 87-year-old guy who had bilateral buccal pappus ankles when he was 75 back in 2005. And they'd failed very rapidly. Many of the mobile bearing implants do tend to fail that sort of timeline. But a wait and watch policy, because there was no revision implants. They weren't my patients. They were sent to me after they'd been watched for 7 years. And then the surgeon that had done the implants in 2005 handed them over as he retired in 2017. So at this point, the patient couldn't walk. He was already 87, and it's a very difficult scenario. And this is the x-rays. So you can see there's been gross osteolysis, huge bone loss on both sides, huge defects, and the guy's in severe pain. So the right side was worse than the left, so we started with the right, and I said, well, the solution here would be a tibio-talocalcaneal fusion. When someone presents with the problem, obviously you want to know, is it failed? Are there any other issues? Well, clearly in this situation, there was undoubtedly tendon issues. There was undoubtedly adjacent joint pain, and clearly there was no evidence that this wasn't coming from the failed ankle. Obviously, I also ask, is there a suspicion of infection? Well, there was a low suspicion in that situation. How much bone stock have you got? Well, clearly in this situation, not a lot. And he's 87. Is that an aging issue? Well, I think biological age is more important than the actual age of the patient. And he was a young 87 that wanted to go mounting on long climbs up mountains. So we start with the right side. And this is actually the case that we did. I did this at the Royal National Orthopaedic Hospital in Stanmore. And basically, there was huge metallosis. The front of the tibia was grossly loose. You can see here, it's literally the whole front of the tibia was mobile. We've taken off the fibula, and the whole joint is utterly black, absolutely black and filled with metal debris. And you can see the front of the tibia is completely loose. So what had happened is the poly had failed. There was metal on metal, and when you get metal on metal, like you do with hips, you can get this metal metallosis, and it's awful black material. It traveled up the fibula, right the way up the fibula. You can see here up the neck of the fibula. It was going up into the marrow of the fibula. There was no healthy bone whatsoever. And he went and had a TTC, like Mark had alluded to. So you had a femoral head allograft and a nail that went up through the center. The problem, as Mark then alluded to, is it resorbs. There was no real healthy bone for it to go to. The blood supply is awful. And effectively, we had a non-union both at the ankle and at the subtalar joint. So I dynamized it, and we tried everything. We give him exogen, all of the everything that one can do for these cases you can do. It eventually settled. He was mobile, but wasn't enamored by the outcome, and he came back to see me and said, right, now what do I do about the left one? I'm happy to leave the right one now, but what I do about the left is actually ruining my life now. So what do you do? Well, at this point, I didn't fancy doing another tibia-talar calcaneal nail, because I just, the function isn't great, and he wasn't enamored by his own thing. He's already 88 though. So we looked at the scan, and what you could see again with the mobile bearing, this often happens, there was malalignment, there was huge osteolysis. And we said to him, well, look, there's a possibility that what we could do is take out the talus was completely, there was nothing there, it was just a shell of talus, and the implant had fallen into the cysts. And we said, well, the best option that we could do is either to do the same, or to take it out and do a total ankle replacement, total talus. And he said, well, you know, what are the results of these? This is going back to about 2017, and spoke to Selene at the time, and we said, well, this is a promising technology, but I can't tell you the longer term outcome. But he wanted to try it because he was not enamored with the other side. And the challenge you've got is that to get the tibial side done, and I use Prophecy, so this is an Envision plan, they don't make a total talus. So this is then Right Medical, now Stryker, and they don't make a total talus. And so you're asking them to produce you a plan for the tibia, even though you're not going to be using the talus. And in this situation, one could have put a plate on, but there really wasn't any bone in here at all. It was a shell. And obviously you can see the implant was mal positioned originally. And the next question is, well, if you're going to make a total talus, it has to be a different company. Is the cartilage on the subtalar joint, on the talonavicular joint, intact? And that's a difficult thing to be able to see. But we felt on the non-loaded scan, it probably was going to be okay. And then the next question is, well, how do you make the talus when you haven't got one to do? Well, luckily we had a shell here, so we could actually make it from this side. Often you use the contralateral side. There was this tibial cortex defect, which we were aware of, and that was going to persist even after the implant. And so that was going to make our x-rays not look very sexy. So what you then do is you have working with two companies, and you have to talk to them individually, separately, and trying to coordinate the two. And the biggest gap that I had a concern about was the alignment, the rotation of the tibial component and the rotation of the talar component. Because if you get that wrong, then the whole poly wear will be asymmetric because you've got it wrong by a few degrees. And so what we actually agreed to do was to make 3 sets of implants in 3 sizes. So we had 9 implants, 9 talar implants, each of them with 3 degrees of external rotation aligned. So you had a 0, 3, and 6 and 9 degrees alignment for the tibial articular surface, which was matched to the in-bone articular geometry. And so this is the implant. So we had it made, we had the different degrees of rotation, and as a backup, you've always got to have a plan B. We had an option of doing not just a femoral head, but this time using a cage, as Mark had alluded to with the nail. So this was an expensive case, complicated case, and one that we had everything out there, including the kitchen sink. And this is what I was talking to you about, the rotation. You can see here it's malaligned. So there's the tibial mark, the red mark, and this is the wrong talus. So we changed the talus around with my extra degree of rotation, which made I could align and get the perfect axial rotation. There's the total talus with the articular surface, and once it's in, it looks like that. And I guess the question is, what's the outcome? Well, this is the guy coming back at, I think, about 6 or 8 weeks post-op. And on the right is his TTC, which he's not that happy with, very little motion, normal looking motion on the side that we've got so the left side is the one we've done the total talus. And you can see clumps a bit on the right. And I asked him to just go over and show me his function. You can see the right side, which has a TTC, has minimal motion. The left side is pretty normal. And what's interesting is when I asked him to show me where the pain or any pain was, he lifted his right side, which is the one with the TTC, and stood on the one that was post-op and balanced on his leg where he's had the total talus with the ankle replacement, showing me where the pain is on his TTC, but delighted with the other side. And I was delighted at that point because he's standing and balancing on the leg that he's had replaced. So I had my proof of concept, if you like. Sometimes they become a little bit more complicated. Just to give you a quick example of another one that came through. This guy was 29, he was a paraglider and fell and landed and broke open talar fractures both sides. Most of the talus was left on the hill. Overseas, they'd operated him, they'd excised the talar body, and they docked him for a TC fusion. So his calcaneum was now sitting up at the talus, and you can see there's a divot out of the back of the calcaneum. So he then approached me and said, could you do a total talus on me? And I guess the answer was, well, not really, because you haven't got anywhere to put it. So in essence, I worked closely with the surgeons from his native country, and what we did is we put on a frame. I traveled over them and flew to his country, and then we put on an external fixator. We had to do an open debridement because it was full of scar tissue. There was no distracting possible. It had been about 4 months that he'd been in collapse. And there, so we excised all the scar tissue. His tib post had dislocated or subluxed outside. We had to replace that and put back the retinaculum, and we had to clear out all of the tissue. And the most important bit was looking at the talus, the calcaneum. The articular surface had gone. There was no cartilage left, both on the ankle and on the calcaneum. It had just been osteolysis because it had been so long. So we were then faced, could we now distract it and then do a total talus? Now, the plan that we found, the original one, was mashed up like this, but the contralateral side had a relatively normal talus. So what we did is we used the contralateral talus, flipped it for this side, although the CT of the planning for this one had no talus. And then the next question is, where's the foot's going to go? Because the foot was in inversion and in varus, and so we had to guess where the foot was going to go and end up. So this is the picture of where the foot is now in white and where it will become in pink. And so that's a really important consideration. You've got to work with your engineers to say, where will the final position be, so you know how to design your talus. The next challenge is went to Stryker at the time and said, I need to do an in-bone report. And they said, well, we won't do it because there's no talus and it's off-label and you can't do that. So what we ended up having to do is do a non-clinical one. So this is for research purposes only. And we did the report, but we didn't have any jigs made. And this was purely so we could see what we were going to be using and the sizing, but we didn't have any ability to do patient-specific because this was so off-label that there wasn't a talus to use. And then with that plan, go back to the next company, and this was in fact Additive Orthopaedic, which is now owned by Paragon, and we designed the total talus, and because there was no articular surface, we had the screws going through into the heel, and that went extremely well. And he's only now about 4 or 5 months post-op, but he's now mobilizing, doing well, and we're now looking at his other side. So although he's very young, this is clearly a concern for longer term. But what's the alternative? It was a below knee amputation. I should argue that there is no company that has a total talus and an ankle replacement off the shelf, but Paragon have actually got FDA approval now for an IDE study, which is basically a study to allow approval, which will be for its smart total talus system, which will be a total ankle replacement, the apex in their case, linked to a total talus. So I think it's getting exciting, this area, and I think it's going to become more and more interesting. So in summary, total talus ankle replacements are possible. The early results are optimistic. I'm very pleased with the early outcomes, but the reality is I've got no idea how long they're going to last and what they're going to do and what to do if we have to salvage. Most of the solutions are off-label, and that's a challenge as well, which we can talk about in the discussion. And clearly there's a need for more research and longer-term data. Thank you. So final talk now, I'm going to hand over to our real expert on this, Mr. Sharpe. So over to you, Ian.
Yeah, so thank you very much, Andy, and to Selene for organising this amazing event today. So I'm being asked to talk about my personal journey of experience and challenges. These are my disclosures. I've got some educational contracts. I'm from the deep southwest of England, which is a nice part of the country to live, with some beautiful beaches. And I've actually spent most of the day flying Spitfires, or being flown around in Spitfire. So that was an amazing day. And this is a picture from over the south coast of the UK to prove it does shine. The sun does shine some days. So I'm from Exeter. So this is the Exeter STEM, which is of some relevance later in my talk. And when I started in Exeter 25 years ago, there was me and no other foot and ankle surgeons. So now I've got a team of 5 of us and a fellow, which again is some relevance later on to my journey towards total talar replacements. So I'll have a quick chat about my journey, why I considered using a talar replacement, some barriers to the introduction within my unit and within the NHS in general, how you get into the OR for the first time, and what the future may hold. Some of what I'm going to say is kind of overlaps with what the other speakers have told already. So my journey to kind of custom-made implants began about 26 years ago when I was a registrar, and one of my consultants had this case of an ankle that had failed, and he designed this implant here, which looked like this. So that looked rather chunky. What he'd failed to work out is how he could put it in. So he put it in like this, which was a fairly eccentric kind of solution. I became a consultant, and then I was presented with cases like this, and I thought I was pretty cool. So I did an in-bone on one side and put a femoral head in the other side, and felt quite happy with myself. But you should never think you're good, because things are always going to come and get you when you're not expecting it. And as we now know from a lot of the literature, and as the experience of Andy and Mark has already said, the femoral heads tend to disintegrate, dissolve. They need to start putting cages in. So that was the start of my reconstruction journey. And then later on, I very similar journey to Andy and Mark. I started seeing cases of AVN, and this was one of Mark's cases. And he started talking about total talar replacements. I thought it looked quite nice and shiny. It looked like a good solution to a difficult problem. So I started thinking maybe we could introduce this to our unit. And this patient then came along. She'd had an innocuous, well, not innocuous, but a talar fracture, which had been fixed elsewhere. Initially, she felt she was doing quite well. And then gradually the talus began to disintegrate. And we can see total talar AVN here with disruption of both all the joint surfaces. So I thought this would be an ideal case for a total talus. So I had to take the principal to my governance oversight committee to allow me to do it within my hospital. And as you can imagine, they went, no way are you allowed to do such a ridiculous operation. So I said, well, we have the hip team. They've got a nice shiny hip. They put those in, they go wrong. And then what they do is they replace the femur, and the knee team come along and replace the knee. So why is me replacing a talus any different to the hip and knee team putting metal in instead of a femur? So I won that argument. Then you have to go through something called the clinical effectiveness committee. I was able to present to them the emergent evidence and literature that taluses were becoming a possibility and did have some limited evidence. I also had an experienced team around me with several experienced surgeons in all aspects of foot and ankle surgery. We had a good microbiology team, and I felt we could therefore say we were ready for such a process. In the UK, we're trying to develop ankle arthritis networks so that patients get access to care wherever they are. And I took this case to our ankle arthritis network, and it was agreed that it would be suitable for total talus. Funding was then an issue. My clinical effectiveness committee didn't want to fund it from the hospital coffers, but we were able to get this funded through specialist commissioning funding in the UK. So we were ready to rock. What was next? So the design process, as Andy has already alluded to, can be complex and involved. So it does take several weeks to design the implant. So we had long discussions with the design team and came up with a solution here. We decided to use a segmented talus. So if at any point in the future you need a total ankle replacement above, we could detach the talar surface and replace it with a suitable one for whatever implant we were going to use. Logistics, we eventually managed to get the go-ahead to have it printed, and just before we're about to use it, our junior doctors went on strike, and then just as about to use it, the implant had a scratch in it, had to be reprinted. So eventually we had a nice shiny implant, all the kit are ready. And in the UK, what we tend to do is complex operation, we do dual consultant operating. So we managed to get special permission for our job plan to have dual consultant operating and with a surgical fellow. And actually the operation itself went very well. The self-retainer is there purely for photographic ease. Managed to get the talus out fairly easily. Prepared the subtalar surfaces with burrs to allow for bony ingrowth, and put some magic pixie dust in there to help it grow in, and we had a good result so far. So we were quite pleased with the process, which needed some streamlining. So this patient then appears in my clinic. This is her left side. She's rheumatoid with an infected hindfoot nail which has been removed. But on her right side, she has a failing buccal pappus Mark 1 implant, which has been in there many years. She's now virtually immobile and would like to try and regain some mobility because of her failing right ankle. So the discussion here is, how can we approach this? So as Andy alluded to, there are difficulties with different implant companies. So the first thought I had was, well, we should do a talar cage. So we designed this one. Then I thought perhaps we could do a revision ankle. So we'll design this one, both of which didn't seem great options. So I thought, well, if we resect the joint surfaces, we could then potentially implant a ankle and a talus and a subtalar fusion. So this is the implant we now have designed. This again, this is pushing the envelope. The patient is very aware of the complexity of this procedure. With shared decision making, she accepts the high risk. So going forward, hopefully my journey is now leading me to offer patients some options other than total talar fusions. So here's how I felt at the start of this process, coming towards a precipice. I've now jumped in. Others may follow, and we can see how the total talar journey is going to go. So in summary, as you've heard tonight, there is emerging evidence that talar replacements are a valid option. I think teamwork is essential, both in the clinical team, both in your local hospital and around the UK. I think most of us who put total taluses in the UK do like to discuss it with our colleagues. You need some managerial buy-in. This is actually a valid option. And we need a lot of industry cooperation, both in the technical design aspects and some logistical aspects. I think network working is something we are pushing hard in the UK, so specialists are available to give advice and offer complex surgery to patients. And dual consultant operating, something we're pushing hard as well. These are complex cases, and two heads are always better than one. And we're thinking about how we're going to get these implants onto our national joint registry, so we'll be able to assess the final outcomes of these on a prospective basis. And as always, feel the force, and back to Andy now so we can take some questions.
Great talk, Ian. I think pretty much everyone said everything. I mean, what I guess the question for me is there's been a lot of, as always with these things, going to be reporting bias. No one likes to publish failures. What do you do if these don't work? What's the get out of jail clause?
Well, ultimately, all my patients counselled the get out of jail cause is a baloney amputation if they don't want to try a cage or a further fusion. But I think most of these patients are coming to me not as last gasp, but aware they have a severe problem because they've either come as a tertiary referral or have come knowing they've got a big problem. So it sounds harsh, but I think that is a reasonable. Well, they're definitely all consented for that. Don't know how you approach it, Andy.
Yeah, I think that's absolutely right. I think it's really essential that when you consent them, that it's a very clear that both are aligned and both know what the next step is. I think the difficulty, I think, is what do you do when you have someone with a total talus for AVN and they start getting pain? So have you had that yet in a total talus for AVN where they coming in with subtalar pain or talar navicular pain?
Not yet. I mean, I'm only 2 years in, so I'm sure they're going to arrive. Yeah,
They're presumably easier to salvage, I guess. Though those ones you can
we could pop it out and do a cage fusion if it's just a talus by itself.
Yeah,
remove it, and then you got a complex fusion, which is what you may have had before you put the talus in. So
your talus in that you had with the double top, the top with the how would you get that out? Let's say the patient now needs an ankle replacement and you go in to take it out. How are you going to get the Morse taper vertically out when you got the tibia there?
Well, I'll probably have to cut some of the tibia away first, get some distraction in. To be honest, I think I'll probably difficult to get that Morse taper apart because it's locked together too well. So I may not have that problem.
So the way I've designed my ones is I've put the angles in the angle that you're going to lever from the front. So I've not done the Morse taper. I've just put two little tiny pegs like a reverse infinity, but going down into the talus. So I think that's
nice balloons, Andy. That's very nice.
I don't know how that happened. I think that's probably tech support saying your time's up. Toby, tell us about outcome measures. What should people be doing to measure outcome for this?
So again, it's very difficult. So I think functional outcomes, like with anything, we've got the issue in foot and ankle, haven't we, where people are using different outcome measures. So I think that is one of the things that we've got to look at generally, standardizing functional outcomes, because that's the most important. So I think specifically things like our MOX-FQ, EQ5D, visual analog score should be monitored to make sure that patients actually are doing well. I think radiographic markers are important, but actually the functions are most important. And then looking at survivorship, but again, as we just had that discussion, survivorship isn't always the easiest outcome with these, because it is a difficult thing to revise. So as in the shoulders with reverse shoulder replacements, where do we go? So I think the functional outcomes are the most important thing for making sure that they're doing well. Great.
Well, I think that's a nice segue into the next topic, because I think the Canadians are on, and Mark Glazebrook's the ideal person to recommend how to look at standardizing the reporting of the outcomes of these things. And so without further ado, I'd like to thank all of the speakers for an amazing seminar on a emerging subject. And thank you, Selene, for having us and hosting us. And we'll hand over the gauntlet now to our Canadian colleagues.
Hey guys, thanks so much. Sorry I couldn't kick you guys off, but thanks to Stryker for sponsoring this last hour, and great talks, guys.
Thank you.
Appreciate it. All right.
Thanks, Selene.
Thank you.
You're looking young and fresh for someone that's been on for 23 hours.
I'm hitting into the 23rd hour now. See you guys.